Ankle arthroplasty through an anterior approach has become an accepted form of managing end-stage ankle arthritis. It is well documented that there is an increased risk of wound healing difficulties with this approach. The reason is that it goes directly through the middle of the anterior angiosome. The typical location of delayed wound healing is on the medial aspect of the wound at the level of the ankle joint. In this picture, the hand is on the medial side. This is the typical area that one sees delayed wound healing or full thickness necrosis in patients at risk. The reason being is that this area of the ankle is fed by retrograde flow because of the incision being through the middle of the anterior angiosome. What I would like to show you here today is the extensile anteromedial approach. We've been using this since 2014 and since that point have not had any major wound healing difficulties. This approach takes advantage of the anterior angiosome, which is fed by the anterior tibial artery and the dorsalis pedis artery. Where I'm drawing these lines is the area at risk of wound healing difficulties through an anterior approach. This area is fed by retrograde flow from the posterior tibial artery if an incision is made through the middle of that angiosome. The posterior tibial artery sends choke vessels or feeding vessels that connect to the anterior tibial and dorsalis pedis artery. This allows the two feeding vessels to the anterior and medial angiosomes to communicate. In patients at risk, this flow can be compromised, particularly in diabetes, smoking, obesity, or in very thin people. This is the lateral border of the anterior angiosome. Anything lateral or posterior to this line is fed by the perineal artery. This is the medial border of the anterior angiosome. Anything medial to that line is fed by the posterior tibial artery. Centrally, the anterior tibial and dorsalis pedis artery feed the anterior angiosome. The anteromedial approach takes advantage of the border between the medial and anterior angiosomes. The incision extends to the corner of the ankle articulation, just above the medial malleolus. A full dissection is taken down to the extensor retinaculum. Then the extensor retinaculum is opened proximally, and as we get more distal, I use the tibialis anterior as a cutting guide to transect the distal aspect of the retinaculum. The retinaculum is thickest over the ankle joint itself and just proximal to it, and is thinnest distal to the ankle joint. You can see that we're exposing the tibialis anterior completely and then transecting the extensor retinaculum. There have been concerns in the past that exposing the tibialis anterior can lead to adhesions and decreased range of motion as far as the ankle is concerned. We have not experienced this in my practice. Stay sutures are then placed through the lateral flap. If possible, the extensor hallucis longus tendon is incorporated into the stay suture to keep the flap intact and to create any disruption between the dermis and epidermis. After the stay sutures are put in place, cautery or knife is used to dissect in an anteromedial direction down to the capsule. There are choke vessels in this area which are cauterized away from the anterior tibial and dorsalis pedis artery so that vascular structure remains intact. As you go through these fibrous strands, the lateral neurovascular structures and tissues retract easily, and one can dissect towards the center of the ankle joint, maintaining vascular flow. There is a constant vessel which comes from the anterior tibial artery and extends proximally. We try to preserve this vessel if we can. In 80% of cases, the ankle arthroplasty can be done through this approach. Here I'm showing the choke vessels. They're in a standard location. One is just distal to the ankle joint. Another standard location is just proximal. These choke vessels have to be cauterized in order to obtain exposure. Here I'm preserving that one vascular branch that I discussed earlier. You can see that we've reflected the lateral tissues to expose the central aspect of the ankle capsule, and now we will work through the ankle capsule to expose the ankle joint. The structures are reflected, the capsular structures are reflected medially and laterally. One of the concerns with this approach is exposure of the ankle. You will see that once we've finished our dissection, the ankle is easily visible, even all the way to the lateral gutter and the fibula. Dissection on the medial side is taken only so that we can see the medial malleolus, but is not extended too far medial. This is the lateral side. I transect the capsular structures with cautery and use blunt dissection to develop the flap proximally. That strand of tissue that you see extending towards the anterior lateral aspect of the proximal tibia contains the vessel that we're trying to preserve. As one can see, even though we've used an anteromedial approach, adequate visualization of the entire ankle joint is possible, and work can be done just as easy laterally as it is done medially. On the upper border of your picture is the lateral side, and you can see that we have adequate exposure. I do take care not to use cautery in the gutters, particularly on the lateral side, as there's a feeding vessel in that location. After ankle implantation, tourniquet is let down, closure is standard. The capsule below is closed with 2 Vicryl. It is easily closed now without disrupting the neurovascular structures because they have been mobilized in a lateral direction during the initial approach, and there's a lot of capsule tissue left to sew through. Now we're taking the extensor retinaculum at its thickest point, which is just at or proximal to the ankle joint. The tendon is gently pushed down to create room to do our extensor retinaculum closure. Closing in layers is very important, as if for when there are wound healing difficulties, the ankle joint is not immediately exposed if the wound healing problems are superficial. Once the extensor retinaculum is closed, then subcutaneous tissue is brought together with only several subcutaneous sutures. I do not use extensive amount of subcutaneous tissues as they themselves can disrupt blood supply to the skin edges. We close the proximal aspect of the wound with staples. Also, a few staples are used distally, and then the corner of the flap is closed with 3-O-Proline, as studies have demonstrated that 3-O-Proline is the best for blood supply to the corners of the skin with closure. One can see that the entire anterior angiosome has been preserved, particularly at the ankle joint level, where wound healing problems are most common. This is a picture of a patient that had a pilon fracture through a medial approach. We've used her old medial incision to create the flap, and you can see that adequate exposure of the ankle is possible, and closure leaves you with a well-preserved anterior flap to cover the ankle joint arthroplasty. The extensile anteromedial approach takes advantage of the border between the anterior and medial angiosomes. We have used this approach since 2014 and have had no major wound healing complications, taking into consideration that proper patient selection is vital.